Alright guys, now we are doing the laboratory medical technology. Okay, you are already here. Oh, this is kind of nice. Oh, fuck.
Of the clinical laboratory education. If you are a student in our program, this is where you spend a lot of your time. This laboratory holds 36 people. A couple of things I want to point out in a clinical laboratory that sets it apart, we're inspected all the time. So our bench, this little countertop in the laboratory is called a bench. Okay? So if you hear people working on the bench, that means you're at a physical place where you can do a laboratory procedure. In the laboratory, we do not do experiments. The reason we do not do experiments is because we're working with actual human patient samples. Blood, urine, microorganisms from wound cultures, we do all that here. If you look on these benches, there's 6 hexagonal benches, which means we can hold 36 people. We have a lab going on next door in blood banking. They're doing ABO grouping, RH typing. But I teach my hematology course, our PATHAs. This is where they do their grossing. They have a camera, they do the measurements. If you look behind where Mr. Beatty is, we have a CO2 incubator and a hood, a BSL-2 hood. Can anybody know what a BSL-2 laboratory is? Well, on this campus, this is a BSL-2, which means you have to have some degree of personal protection. This sink here, we're not doing anything, we're not doing procedures, but if we're doing procedures, you have to wash your hands. Why do we have a hand washing sink there instead of over there? It's accessible there, that's close. In a laboratory, the sink closest to the exit is your hand washing sink, and every other sink is something else. We have an eye wash, we have a body wash in case you don't hit that triangle because there's 55 gallons of water over. We have eye washes. So we try to do laboratory safety is our biggest thing. The most important thing when we do the laboratory tests, in this case we do laboratory tests for the student lab, we make sure that everybody is safe, everybody has the opportunity to do what they're going to do. These chairs, believe it or not, are about $800 each because they cannot attract any type of spill. People spill stuff. You see the absorbent pads we have. So we do everything that we can do for laboratory safety. What you're looking at now, we have calicide, we have disposable pipettes, we have biohazard bags. So one of the cool things you're going to do is when you're doing laboratory procedures, you need all the resources. In the sharps container, we do a lot of glass slides. So personal protection, safety, it allows us to do all the experiments. If you're a student here, we'll teach you every aspect of a microscope. In the military, they teach you how to know everything about a rifle. In a laboratory, you will know everything about a microscope. Every lens system, the stage, the condenser, how to adjust it, how to get best contrast, how to get best resolution, how that no one else can see. And we'll teach you how to focus a microscope to your eyes so that there's no double vision or anything like that. You don't have to have 20/20 vision. You can look at a microscope with glasses on, glasses off. We're going to teach you all that. Therefore, when you're looking at specimens, you can make them. You will be the one in the laboratory that makes the medical decision, and it makes it. We base those medical decisions on many times on what we personally observe in the microscope. So microscopy, utilization of a microscope is huge. All other laboratory instruments we do. In microbiology, we do a great deal of specimen ID or unknowns. In hematology, we do a lot of diagnosis with anemias and leukemias. So this is ground zero. This is where you can have a happy home for 2 years with us, and then once you're done, you'll go on, take your boards, and you work as a clinical laboratory scientist. Are there any questions? Okay, well, I'm going to turn it back over to Mr. Beatty. Thank you all for being here. I just want you to see where we are. You can kind of wait. This is our first room. Everybody gets their own microscope. They get everything. They get the lab So everything, this is where you come with prep.
And I will meet y'all in the hallway. Y'all can go first.
Alright, that's the health center. And we're gonna be walking. We're gonna be walking. Alrighty. See? Walking. Just walking with the roof.
Welcome. My name is Denise Nastars. I am one of the faculty and program director for the respiratory therapy program here at UTMB. I heard that at Dallas College there is a respiratory therapy program there. There's different levels of programs, so we have a master's in respiratory care. Master's level. Dallas College, I'm assuming it's probably an associate level, and then there's the associate level, there's bachelor's level, and then there's a master's level. So our program is a master's level. All three levels of education can get you a job working as a respiratory therapist in a hospital. Everybody takes the same board exam at the end of their 2 years in school. And then we have two different types of credentials. You can be a certified respiratory therapist, or you can be a registered respiratory therapist. The registered respiratory therapist is pretty much the level that you need to be at to be hired at most hospitals. You can be certified, but more than likely at the big hospitals, major hospitals, they want you to be registered. And that's just passing at the higher cut score versus at the lower cut score. And then you take a second, that qualifies you to take a second exam where you get a bunch of different patient scenarios and you take that exam. And then you become a registered respiratory therapist. Then you just apply to get your license to practice. Having that credential, you get to get your license to practice and be a respiratory therapist in the state of Texas. If you move, your credentials follow you wherever you go. You just have to apply to get a license to be able to be a respiratory therapist in that state. It's just a matter of paying a fee, showing them your credential, and then you have to do continuing education from here on out. Healthcare changes all the time, so any type of healthcare field that you get into, you're going to have to do some type of continuing education because you need to keep up with what's new and out there and stuff. So continuing your education is important. All right, let's get to the good stuff. So I just kind of put a bunch of different types of equipment that we use as respiratory therapists in this room. This is kind of simulating an intensive care unit room where respiratory therapists work. They work in all areas of the hospital, from the ER to the intensive care units, to the floors, to outpatient, just doing pulmonary function testing, sleep studies. We work with all different patient populations, from neonates all the way to geriatric patients, and everybody in between. Everybody has to breathe. Everybody has to have an airway. We don't just deal with pulmonary diseases, but that's a big chunk of what the type of patients that we deal with. Anybody that loses the ability to maintain their airway. So somebody who maybe had a car accident, maybe had a head bleed or something happen, that they're not able to breathe correctly or maintain their airway. People who have major surgeries usually have to have an airway for that. So you don't just deal with patients with pulmonary diseases. We do a lot of education, making sure that people who do have pulmonary diseases are taking their medications correctly and they know what they're taking. And it's really important to be able to understand your disease, being able to understand the medications that you're taking so that it avoids you from going into the hospitals. We do a lot of education. In the intensive care unit, we usually maintain patients who maybe weren't able to maintain their airway and had to have an endotracheal tube placed. Once we establish the airway, we have to breathe for them. So that's what this machine is. This is a mechanical ventilator. It comes in all different types. This is a Hamilton one, but there's a bunch of different companies that have different types of. So I wanted to kind of show you that. We have a lot of different therapies that we give. So we give, this is the Metaneb that kind of vibrates the chest and delivers medication so people kind of help cough up if they have a lot of secretions and stuff. So as a respiratory therapist, you have to be able to deal with the secretions. You don't have to deal with poop. Anything from the waist down, you don't have to deal with. But any type of secretions, you have to be able to stomach that.
PT&OT.
You'll see a lot of phlegm and stuff. Huh?
PT&OT deals with poop.
Yeah, PT&OT deal with poop, and we just we'll help them. You know, if something happens, you need to be able to be okay with helping them. But you will see a lot of phlegm. You need to look at it because that phlegm is going to give you a lot of information. The color, texture, and all that. So you have to be okay with that. We do draw some blood. We do arterial blood gases, so we might stick patients to draw blood because that's going to tell us how well they're ventilating and how well they're oxygenating. Right? So basically how well they're breathing. All right, so we got this guy here, and then we also do high flow nasal cannulas. We have a lot of different equipment that they're responsible for maintaining, delivering medications, delivering different therapies, basically helping people get better. And educating them in the fact we have different ways medication is delivered. We have to educate them about that. If a patient needs oxygen, we have a lot of different oxygen delivery devices that we can give to them. If there's a code situation, airway, that's responsibility of the respiratory therapist. We're always at the head of the bed, seeing everything. There's some hospitals that respiratory therapists will actually insert the intratracheal tube. They'll do the intubation. But if they don't do the intubation, they'll definitely be there assisting the physician, whoever's doing the intubation, by helping them. We'll breathe, bag mask, ventilate the patient. And then once the airway is established, we'll secure it, listen for breath sounds, confirm that it's placed in the trachea and not in the stomach, because you got two tubes. You have the trachea is in the front, esophagus is in the back, so you got to make sure you're in the trachea. Else you'll just have a belly full of air. All right. Any questions?
Can you show us something?
Something that we do?
Yeah. With that patient.
Well, we have this. I brought this here so we can get a little hands-on. So this is an intubation head. So our students will practice doing intubations and doing airway placement. So the endotracheal tube, this is what it looks like out and not inserted into your lungs. And so this right here, it has a little balloon at the end that we inflate right here. This is inflated. So it kind of keeps, so all the air goes into the lungs through the tube and not escapes around the outside. So this is what it looks like. It goes through the vocal cords, so when somebody's intubated, they can't talk. So that's why they can't talk. Alright, so you guys, so once it's inserted, we'll listen to make sure that it's in, when I talked about earlier that it's inside the lungs. And so when it's inside the lungs, we'll breathe form. So that'll cause, when your lungs inflate, it causes your chest to expand. So we'll listen for breath sounds on either side, and then make sure that we have it on there. So you can see underneath here is the esophagus, right? So we'll know if you don't get that chest expansion, then you know that you're not in the lungs. They're not in the lungs. There's also a little device that we put in between here that it has paper in it. It's entitled CO2 detector. So when we exhale carbon dioxide. So that if it's in the lungs, then that paper is going to change colors because you're exhaling CO2. If it doesn't change colors, that means your like doesn't have CO2. So we'll confirm placement that way. They'll get an x-ray. You guys are welcome to come, and anybody who wants to bag. And so if you're not awake and coherent, then we need to go in there and get it. So we'll suction. So we have this right here is the size. And you'll just advance it. And then they'll usually cough. And then you'll have this unlock. And you'll apply suction. And then you'll get the secretions out that way because they're not able to clear them themselves. All right, so we do a lot of suctioning. Let's see. You guys are welcome to.
What about the blood? Because I know the guy has the things or the
The IVs, yeah.
Yeah,
Arteries. And usually we'll do on the radial artery right here. So where you feel a pulse, that's your artery. All right, and so we'll feel for that. Pumps it into the lungs. The lungs drop the lungs will put take the CO2 out from the blood, and then the oxygen will go into the blood. It exchanges. You have that oxygen CO2 exchange. CO2 is like the waste product. That's what we exhale out. So when the blood goes through the lungs, right, it's going to have the oxygen is going to be picked up, and then you'll also have CO2. And so we'll be able to draw from the artery and be able to find out how well they're breathing. If their CO2 is really high, that means they're not breathing very well because they're not getting rid of CO2. If their oxygen isn't very high or it's low, then that means they're not getting oxygen into their lungs and it's not getting into the blood. So that means there's something wrong there. So we fix whatever's problem. You can have both happening at the same time. Makes sense. So we do a lot of things. We work right alongside of the nurses, physicians. Our job is to, once they're on the ventilator, we maintain that. And then we also assess them and try to get the tube out, because we don't want the tube to stay in there for a long time. It's just temporary until they get through whatever's causing them to be ill. And then once they get better, and we do different tests to find out if they're ready to take that tube out. So we need to assess, if we take that tube out, are they going to be able to maintain their breathing? And so we do different tests, and we'll talk to them, coach them, and then see if they're strong enough. And if they are, then we get to take the tube out, and it's a happy ending. And then sometimes we have to put them on something else that helps their breathing. That's not necessarily this extreme, but it's like a mask that helps them to breathe as well. During COVID, respiratory therapists because it all affected the lungs, so they were right there front center, doing a lot of therapies to help the patient. Questions? Anybody wants, you can suction, you can come take a closer look at the ventilator. I'm gonna hook it up to here because it's obvious.
He can't breathe. He can't breathe.
We got little lungs on here. This machine really does show us information that we're able to make some changes for the patient.
I have a question. Do y'all have like the mannequins that talk? Like, you know how like the
Yes.
people who
So
talk?
he can.
No. Wait the damn minute now.
Open his eyes. I can get him to cough. Let me go and we're gonna extubate him. He got better. We're gonna extubate him.
Look at him blinking.
Balloon at the end, so I gotta deflate it or else I can't pull it through the vocal cords because that'll hurt. Because I don't want y'all to put this video anywhere and that's not right. You didn't do that, right? It's like when you watch, you're ruined. Once you get in healthcare, you're ruined on Grey's Anatomy and stuff. It's not impossible. All right. You can talk. You can scream. Yeah. That was screaming. It keeps going back to that. It keeps going back to that. I don't know why. But But he can do some things, and we'll have our students come in here and do different therapies. Talk to them, and we're able to. These have very generic responses. But we have a control room that we're able to have, there's a microphone that we can actually talk through as if we're the patient. So our students, before they go to clinical rotations and do these therapies on actual patients, we make sure that they know how to do it. And so they'll come in here and treat the mannequin as if, you know, the actual patient, and we're able to interact with them and talk to them and stuff. We can have him cough. Coughing's kind of a
Mhm.
we can have him throw up. We can also make him get worse. We can make him
Cough sporadically.
we can make him go into asystole and he can die. Or, you know, we can make him get tachycardic after they deliver a medication. There's, you know, albuterol can make their heart rate go up. And so checked off on that, we might have their heart rate go up, and then maybe the patients can be like, my heart feels like it's about to come out of my chest. And then hopefully the therapist will be able to tell them, that's one of the side effects. You know, if it does stay elevated, we can maybe recommend a different kind of medication for you. It's all about education and helping. And so, is anybody interested in respiratory therapy? Does anybody have anybody that maybe takes medications, that they have a grandparent or somebody with asthma that you know in your family?
Me, myself, and that.
Myself included.
All right, so, you know, I don't know if you've ever been hospitalized for your asthma.
Thankfully, no. My brother has them.
Perfect.
Yeah.
Okay, so he definitely had an interaction with a respiratory therapist. They do a lot of the education, and we're called for anybody that needs to be educated. Anybody else who would like to bag the mannequin, you're welcome.
Can I take a selfie with it?
You're right with him?
I can take
Physical therapy lab space. The building right next to us as we were coming over, that's where the anatomy cadaver lab is.
Can we go in there?
No, sorry. Sorry. So that's where if you come here and you're in the physical therapy program, I don't think OT does. I think physical therapy and Path A are the only ones that do cadaver dissection. But this is PT. Today they're having a lab on transfer training. So we just saw someone like in the ICU that might be on a ventilator. And now when they're up and ready to be moved into a wheelchair, then a physical therapist will do that. So they're learning how to do that today. And apparently it's their first day of transfers. So what we'll do is, are they in 2 rooms or 1 room?
Pretty much in this one right now, so that we can file in the back.
Okay.
And
It's a very, very busy lab. There's a lot of
Why y'all not gonna go in? What? This is fucking nice. Can we like go with them? Can we go in?
yes, yeah.
So I don't want to disrupt their. So they're learning right now. So.
Okay, guys, I'm in the physical therapy room where they like transfer the patients out the bed and put them in a wheelchair and stuff like that. So I'm gonna show y'all the stuff this is, and yeah, just like that. You see it?